Senator Kelly, we're live and ready to go.
Okay. Good afternoon, everybody. I'm Dolores Kelly, Chair of the Senate Finance Committee, and we are happy to have this very important briefing this afternoon. Today is very important because we need to understand the impact of the COVID-19 on Maryland's thousands, and in fact, tens of thousands of assisted living residents. This is of great interest to the General Assembly as well as to the public. At this briefing, there is a primary audience of members of 3 legislative committees: Senate Finance, Senate Budget and Tax, and the House Committee on Health and Government Operations. We are holding this briefing today largely because both the state and the press have failed to indicate anything separately during this pandemic regarding the existence of and the state of health of elderly Marylanders and disabled Marylanders who live in assisted living facilities. I guess they've been lumped in with nursing homes, but that's a very different animal. This pandemic is impacting a huge population of elderly and disabled persons. And some of these homes in which they live, assisted living, which is very important to us here, are nonprofit. Some are for-profit. Some have religious affiliations. They are spread across all 24 Maryland jurisdictions, and they are licensed according to various levels of care which they are prepared officially to provide to their residents. Unlike nursing homes, assisted living facilities have no federal regulations, so their availability, locations, and quality of service are totally dependent upon the state of Maryland. Before we hear from our expert panelists this afternoon, I want to bring to everyone's attention today's article on the front page of the Baltimore Sun titled, "State Significantly Underreports Nursing Home Cases and Deaths." Well, if they've underreported that, and if the Sun paper is correct, then they've underreported what is embedded but not specifically mentioned. That is cases and deaths of our elderly and disabled who live in assisted living. Since the state has failed in its reporting to single out and to even separately mention assisted living during this pandemic, we want to take that on this afternoon. We are fortunate to have experts here today to educate us about this population, the regulatory scheme under which they operate, the strengths and weaknesses of assisted living in Maryland, and the organizations of owners and professionals who will have representatives speak to us today and who try to keep the profession honest and state of the art. We will hear from Secretary Rona Kramer of the Department of Aging. She will lead off, followed by Stevanie Ellis, Maryland's long-term care ombudsman within the Office of Health of the Health Department, Healthcare Quality, who will be followed by Dana Kaufman. Dana represents a very large national and Maryland-based network of owners and professionals who do the work of assisted living. And finally, we will hear from Allison Cherokosky, President and CEO of the other major assisted living professional organization. So Dana is representing Lifespan Network, and we also will have Allison representing Leading Age of Maryland. We are going to hear from all of our expert panelists because we know so little and we hear so little sometimes about assisted living that we want to be sure we get the whole picture, the size of the population, how it's spread out, how it is regulated, and so on, before we go to questions and comments from members of the General Assembly. So at this time, why don't we start off with Secretary of Aging, Rona Kramer.
All right, I'm unmuted. Correct?
That's right.
Great. Thank you, Madam Chair and Mr. Vice Chair Feldman and members of the committee. It's lovely to be with you. I've missed seeing many of you in person, but it's good to be able to answer some of your questions today. I have asked Stevan Ellis, the state ombudsman, to join us. Ms. Ellis's role is as the advocate for residents in nursing homes and assisted living facilities. I need to note that she is not in the Department of Health. She's at the Department of Aging. And I'm sure it was structured that way so that her voice would be separate from Office of Healthcare Quality, so that her work is independent of the Department of Health, and even in great measure, independent of the administration and the Secretary of Aging. She has a lot of authority to act independently of the Secretary or anyone else in the administration. And she is very much regulated by, and that role is determined by the federal government. So she will be able to answer a lot of the questions that you have, and you know that her voice is completely separate from and independent of the administration. Before we start, I would like to give you a quick overview of some of the activities that we have had, the work, and it's been tremendous work that we've had to do during this pandemic. As you all know, our constituents are the most vulnerable, and so we have had a huge amount of work to do in many respects. We have expanded existing programs and created new ones in very short order in order to do that. Starting with nutrition. And as most of you know, we have a nutrition program, and on a regular basis through normal times, provide meals both in congregate settings and home delivered meals. As people could no longer go to the grocery store, wanted to stay in and shelter at home and not go out, our responsibility for feeding older adults who under normal circumstances had no problem going out and getting their food became tremendous. And we have increased our home delivered meals from what had been pre-COVID, 40,000 meals home delivered per week, to now where we stand at 190,000 meals per week. That's a 483% increase in the number of home delivered meals. And our area agencies on aging working with us have made that happen, and it has been a tremendous task. It has happened without a glitch and without additional staffing. Slide 3, please. We decided, as we received federal funds in the CARES Act for nutrition, increases in nutrition, that we would attempt to use what we've chosen as 40% of our nutrition funding in the CARES Act with local restaurants, small local businesses, for many reasons. One, it's going to help boost the economy to put what it'll be about $5 million into this effort. And we hope to keep many small restaurants open. But beyond that, for our clients, What it does is it gives them interesting, exciting new food to look forward to. And I think most of us can say that foods become important as life has kept us living at home. And so we're giving now something to look forward to. It also allows us to provide ethnic food, which we don't otherwise always have that option of. And it allows, it's a comfort for people to have food that they grew up with and that's ethnically appropriate to them. And it'll add interest to those who now get to try other types of food. So all in all, we're excited about it and the program is underway. Slide number 4. We started the Senior Call Check program. Can we switch to slide 4? We started the Senior Call Check program well over a year ago. I would like to say that this program was my brilliant idea, but if I do, my life is going to be miserable the next time the Kramer family gets together for an event. Because in reality, this was the brainchild of Senator Ben Kramer, and he is the one that sponsored the legislation that had us set up the Senior Call Check program. It is a daily check-in call. It's an automated call to check in to any older adult, anyone 65 or older in the state of Maryland, and to make sure that they can get to the phone to pick it up, so that we don't have people languishing on the floor after a fall or a heart attack or now COVID possibly, without someone knowing that they are in duress. So as we had about 102 participants in the program at the start of COVID, we are now up to 1,100 participants. So they are getting a daily call. That's the automated. We have added to the program now a daily message updating them on what's happening with COVID, and everything from places that they can go for help, where they can get nutrition, how they can get it from us should they need food, how they reach the Ombudsman, all of our programs. And we roll out messages to them daily. In addition to that, we have also added to the Senior Call Check program a once a week live check-in call, so that we have trained staff who call, who try to get a sense of whether there's depression, behavioral health issues, or very importantly, abuse. Those are things we can check on. Anyone who needs a call more frequently than once a week because they're feeling isolated will have a call as many times a week, that personal call, as they feel is necessary. So we have done a great job with what was a great program to begin with, and it is now much more heavily used. Slide 5, please. Oh, I might note on Senior Call Check, first in the nation to have this program. And I understand that the state of Ohio has copied our program completely to the detail and set it up in the state of Ohio. Slide 5, as you all know, we've been working on opening a durable medical equipment reuse program in the state of Maryland to provide free equipment that is sanitized and repaired to the public, both pediatric and older adults. Just wanted to let you know that program is on time and on budget. During the pandemic, if we go to slide 6, we were concerned at the beginning of the pandemic that people who had family caregivers who became ill or exposed to COVID would be left in the lurch, not having their daily needs cared for And we were also very concerned that they might then be calling 911 and going to the emergency room because they had no one to transfer them out of bed or to help them with their personal needs, going to the bathroom or showering, or maybe they were unable to take their medication without someone guiding them to take it appropriately. So we set up within a less than 2 months, the Caregiver Services Corps, which is now fully operating and functioning. Any older adult in Maryland who has their family caregiver unable on a temporary basis to be assisting them can call 211, and 211 will put them in touch with connect them to our 24/7 call center, which also has multilingual capability. And the call center has medical capability. They triage the call, determine what is necessary, what skill sets are necessary to provide the caregiving service. They send that information from the call service to our hub. And at that hub, we then call volunteers from the Maryland Medical Reserve Corps. We make the connection. We have a connection for PPE if necessary, and we serve the individual. So we have now served, as of a couple of days ago, it was about 100 people, and the caregiving requests are anything from assistance with medication, picking up groceries or medication from the store or pharmacy, all the way to assisting with a long list of personal care needs. We want all of you, all legislators, to know about it, to feel free to send information out to your constituents so that the public knows that this is there to support them. Again, a first in the nation program. Slide 7. We have produced many public service announcements. Some are very long, and they're viewed by 90,000 people at Leisure World on their closed circuit television system. They're viewed in hospitals, nursing homes, assisted livings, et cetera, and CCRCs as well. And they provide up-to-date information specifically for older adults about services that are available, where they can get help, and how to stay safe. Things like being sure that when they're washing their hands, they also sanitize the handle of their cane or their walker, so that they actually, in fact, have sanitized completely. We've done 3 series of these now once a month, and they are also available to your constituents to let them know information is extremely important to them during this process. So that is available to them. Slide 8. Continuing care retirement communities. Okay, we don't have that on a slide apparently. We were asked what information we obtained from continuing care retirement communities during the pandemic. Our role at the Department of Aging is to regulate the financial aspects of continuing care retirement communities. As a matter of fact, we cannot touch health issues because we do not have health expertise, and we got an opinion from our assistant AG on just that issue. There, as you know, are in CCRCs, independent living, nursing homes, and assisted living care, all within the campus of the CCRC. And so the assisted living and nursing home care are regulated by the Department of Health, just as all nursing homes and assisted livings would be. And in whatever way those assisted living and nursing homes are treated outside of continuing care retirement communities. So we do not advise them as to the pandemic and health issues. And assisted living facilities, which you've noted specifically, report for the purposes of the pandemic to their local health departments. And there is a very detailed publication that explains what it is that they report and how quickly they report it. It is all in very detailed directives to the local health departments. And I'm not going to read it all to you. It would make your eyes glaze over. But the concept, the overarching theme is that assisted living facilities are required to report with great haste. It's either within the term immediately or within 1 day, depending on the situation. They need to report the information of any cases or suspected cases to the local departments of health. Many of these assisted living facilities, and Stevan can give you more detail, are not tied into CRISP, don't have that capability as all nursing homes do. So their regulations have them, they're specific, but they go through local departments of health. For assisted living facilities with greater than 10 residents, positive COVID tests are made available to the public on the Department of Health's COVID webpage. When a COVID outbreak is confirmed in an assisted living facility, the local health department works with the facility until the situation is under control. And the local health department provides all necessary assistance, training, guidance, and PPE. And the state works daily, when I say daily, 24 hours a day, doing its best to get the tests and the PPE to those facilities. And I know that you've already heard about that process from the Department of Health. So that is an overview of our work at the Department of Aging. Thank you, Madam Chair.
Thank you. And we'll go next to Sylvan Ellis.
Great. Can you hear me okay? Chair Kelly, Vice Chair Feldman, and me, thank you for inviting me to speak with you today about the Maryland Long-Term Care Ombudsman Program and the residents that we serve. The Ombudsman Program is the advocacy program for nursing home and assisted living residents. The program's authority comes from the Older American Act, which is a federal law. And the state ombudsman is an independent voice for nursing home and assisted living residents across the country and, of course, in Maryland. As you know, this has been an unprecedented time in our history. For long-term care residents, both nursing home and assisted living residents, families, staff, the effects have been devastating, with too many residents and staff testing positive, too many people becoming ill, and too many people dying. Unfortunately, this is not unique to Maryland. This is a national issue affecting all states. I've been meeting weekly with other state ombudsmen, and we're working together to get through this time, to identify needs, the direction of our ombudsman program across the country, and how best to serve the residents we advocate for. In discussions with my peers, Maryland has responded to the needs of the residents and citizens and often exceeded other states. The Ombudsman program has been working closely with stakeholders, state agencies, advocacy groups, the industry, and lots of other people. We often have weekly calls to work to identify needs and to work together to be responsive to the ever-changing times that we're in currently. Before the pandemic, whenever possible, the Ombudsman visited nursing homes and assisted livings on a regular basis. In Maryland, we have 227 nursing homes and 1,654 assisted livings. Of those 1,654 assisted livings, 490 of them are Medicaid waiver facilities, which means the residents have a nursing home level of care if they're waiver participants. We speak with residents, staff, and families to let them know about the program, the work that we do. We provide education and resources. We help resolve complaints to their satisfaction whenever possible. And that's what we did before the pandemic. Now, I want to tell you how things are and tell you about the work through the residents' experience and how it's affected the work that we do. Currently, as you know, there are no visitors in facilities. The routine in facilities changes all the time from what was normal. Staff have been very affected by the pandemic, and often staffing in facilities where there are a lot of positive cases, the staff have to go home. And so sometimes staffing can be challenging for the facilities. The residents themselves in most facilities, including assisted livings, are required to stay in their rooms because of the public health concerns. Activities are being done differently, and often there are things like hallway bingo and virtual activities and a lot of individualized activities. Some places are doing better than others. The impact of all of that is social isolation, a lot of stress and frustration. Sometimes residents don't have access to phones, some do. A lot of residents need assistance using the phones. And adult daycare residents are not attending, assisted living residents that used to attend adult daycare don't go to adult daycare anymore. A lot of the facilities have done a good job combating these issues, but I really do feel that there's a lot more that can be done across the state. And again, I don't want to minimize the impact on family and friends and the staff and the facilities. This has been it's been life altering, I think, for many of us. What we're doing right now, we are calling residents all the time, just like before we would visit, now we're calling them. We're doing virtual meetings. We're scheduling a lot of those with the facility. We're doing a lot more outreach to facilities by phone. And in fact, the first week or so of the pandemic back in March, my staff reached out to most of the facilities across the state. We really have been building relationships with the facility staff, and that's actually been going well. We've been providing a lot of education and resources, because if you've been following the pandemic in our world, that information changes all the time. And I think the folks that are speaking later may talk about that, but they definitely understand. It's a ton of information, and understanding it and helping the public understanding it is really a lot what we've been doing. My staff are working harder and longer hours. There's always more to do. It's harder than it ever has been. A lot of the calls that we have are very difficult with residents and families. And I want to give you an example. We had a call, the email came through the secretary, and I called a family member who has a loved one in an assisted living facility. Unfortunately, her family member was at the end of her life, and she was dying, and the facility initially would not let her visit her mother as she was dying. And so I talked with her about the fact that there's an exception made for these type of visits. And she used the information and was able to visit her mother and be with her when she died. And she let Secretary and I both know how much that she appreciated that. It was probably one of the most meaningful compliments I've ever gotten. It was very bittersweet, but she was thrilled to have that time with her mother. And there are countless of others examples of things that my team has done to help residents and family during this time. These calls are very difficult and stressful for us. The facility is experiencing the same thing with supporting their staff and the families and the residents that they serve. When facilities have COVID, whether it's assisted living or nursing home, we try to focus a lot more on them and try to assist them as much as we can to talk to residents, families, and the staff. A lot of the facilities have done a really good job helping the residents through this and helping their staff understand what to do. It's been very difficult for them, as you can imagine. I want to thank everyone that I work with, the stakeholders, the advocacy groups, my partners, the local AAAs, MDOA, Department of Health, many other people that please don't, if you're on the call or on the virtual, please don't assume I'm forgetting you. You're included in that. But I especially want to thank my staff. They are really working hard, and I believe that they really are the unsung heroes of this pandemic. Thank you for allowing me to speak today, and look forward to hearing the other presentations.
Thank you very much. We're going now to Dana Kaufman, who is representing the professionals and providers in the Lifespan Network.
Thank you very much, Senator Kelly. And again, for the record, Dana Kaufman, I'm with the law firm of Schwartz, Metz & Wise, and I'm here today on behalf of Lifespan Network, and I'm being joined today by Allison with Leading Age. And we're going to basically tag team this presentation. She's going to handle a few of the slides, and I'm going to handle the others. So if we could just jump right in and go to the next slide. And really what we're hoping to accomplish, given the fact that assisted living is a very diverse industry, much more than nursing homes, we're going to give you an overview of assisted living because that really does impact the way that COVID-19 affected the industry and the residents in our communities. And also another big issue, especially much different than nursing homes, is how assisted living is funded, because that also relates back to COVID, especially in how assistance was being provided by the federal government and the state. And then we're going to just end a little bit on the regulatory environment that we're living in right now, because I know that there has been some questions and concerns. So if you can go to the next slide. And just for an overview of assisted living, and I know my numbers appear to be a little bit different than Stevan's. My data is from February of 2020 from the Office of Healthcare Quality, but I had that in Maryland, there's 1,558 licensed assisted living communities in Maryland. What's important about that is if you look down at the breakout that I have on the slide, you'll see that assisted living is actually a small business in Maryland. 73% of the licensed assisted living communities are 9 beds and under. 14% are 10 to 16 beds. So when you're looking at that, you really only have a very small percentage are what may be considered the 17 and beds over or the larger communities. So again, when we're looking at assisted living, it really is a small business. I think a lot of individuals look at it more because they recognize, the big assisted livings that may be on the corner that have 125 residents, but those are really the small percentage. So it's important to keep that in mind. And when you add up all of the beds, it is about 23,687 available bed capacity. That's their licensed bed capacity. It does not mean that those beds are all occupied. So again, the point of this slide is really just to illustrate the diversity of the assisted living community and the industry, and that so many of these are actually very small operators. If we can flip to the next slide. Now going into COVID-19 and the impact that we have had in the communities. And assisted living has been no different, I want to emphasize that, than what was happening in the nursing homes and in the hospitals. We had no more information than anyone else when this came out. And we have struggled to learn information, to understand the guidance, to implement the guidance. And this is guidance that changes week from week. I mean, it's still changing right now. We've heard different things from the World Health Organization and CDC just this week. So again, we're all in kind of this new world trying to figure out the best way to handle and protect both our residents and staff. Now, as far as reporting, and I know that Senator Kelly had indicated this in her introductory comments, and Secretary Kramer also did. So just to confirm, and this is again for assisted living because the process for nursing homes is different, but for assisted living providers, all cases and deaths must be reported through the local health department. And it is that information that is then sent to the state and uploaded into the dashboard that is online for everyone to take a look at. Now, again, the tagline on that dashboard is nursing homes, but again, it applies to nursing homes and assisted living and group homes with 10 or more. So again, if you go back to the previous slide, you will see that a majority, the supermajority of assisted living providers are less than 10 beds. So they would not be included in that dashboard. Now, I had indicated on this slide, since they usually update that, well, they always update that, the nursing home tab with the assisted livings on Wednesday. I had tried to go through to give you a better picture by teasing out the assisted livings and the CCRC cases from there. But I just want to caution that I look at the same information that you have, and to the best of my knowledge, that information is really a snapshot in time. You are correct. It's my understanding that it is not cumulative, but a snapshot, and cases are removed from that. So no one quote me anywhere on this, but when I took a look at it, it did appear that there was about 36 assisted livings listed as of yesterday and about 15 CCRCs. But again, especially with the CCRCs, it's unclear from that report where those cases may have been in their service deliveries, whether it be assisted living, nursing home, or independent living even. But my advice is any information directly related to the reporting, the Maryland Department of Health is the best resource for how that was done. Next slide, please. I'm going to turn this over right now to Allison, who's going to go over the next few slides, and I might chime in here and there. Thank you.
Dana, hello everyone. It's a pleasure to be here today. Chair Kelly, thank you for inviting us to be part of this discussion. I just want to echo a couple things that Dana said around this really being such a novel virus and a novel situation for our entire society, and especially for our field, which we know is most affected by this virus. Providers across the continuum have really been working hard from day one to do the best they can with the information that we've all had, which we know continues to change day by day. So we wanted to share a bit about PPE. So PPE has been and continues to be a challenge. Orders have been delayed. They're not fully arriving. Only partial orders are coming in. Most providers, if you ask them today, I would say they have enough for today. But in a recent poll that our Leading Age National conducted, we found that most providers' current supply of PPE would only last them 2 weeks. And so providers are really working to anticipate what their PPE needs are going to be in the coming months, how to navigate the financial burden of these unanticipated PPE costs. The state stockpile we have found has not been adequate to meet the incredible demand of products that folks are needing to stay safe. Providers are not receiving the full amount that they have requested at times. So Lifespan, HFAM, and Leading Age Maryland did partner to place some large PPE orders and help distribute that to providers across the state, across the continuum of care. And providers have really been working in any way that they possibly can to secure PPE. If you could please go to the next slide.
Allison,
Yeah, sure, Dana, go ahead.
I was just going to add to that with the PPE. So I was listening yesterday, I believe, or was it Tuesday, the House Health and Government Operations Committee also held a briefing with the HSCRC and the Maryland Hospital Association. And many of the issues that the Hospital Association raised were the same issues that we were seeing within our own communities. So for one part, just to be aware, of course, what you've heard, PPE and the cost has been dramatic. price gouging left and right. Unfortunately, those chains, the supply chains, are national as well as worldwide. So it is difficult, even though Maryland does have that price gouging. Now, some of these prices have started to go down, but what we found as associations is that it was more economical for us to take the role. We really did have to pivot the associations and take the role to purchase the PPE. And we were very fortunate. And there was a link to a story that I encourage you to watch where a local physician did provide upfront money so that we could do mass orders. And we have been distributing, which is the picture that's up on the screen right now. But we are still facing issues, even with making sure that the PPE that we're getting in is quality PPE. Last week, Lifespan got an order in from the distributor that we always work with, always have had good experience. Unfortunately, though, the supplier, when we got it, they were armholes of the gowns that we ordered, but you actually couldn't put your hand all the way through. There were no handholds. So we ended up having to turn, of course, give those back. But it's the issue of finding the PPE, making sure that it is reasonably priced and that it is good quality. It continues to be a challenge that we are continuing to work through as associations.
Thanks for adding that, Dana. If you could go ahead and go to the next slide, please. So a couple of other, when we kind of think about the top 3 issues that providers across the continuum are grappling with, it's really PPE, staffing, and testing at this point in time. And so I think when we look at staffing, this is a field where we were already seeing workforce shortages. So it's not a surprise to us that this pandemic has really made things even more challenging. So some of these specific issues are related to staff perhaps being asymptomatic and then testing positive for the virus and needing to self-quarantine, or perhaps they have a known exposure to the virus and then need to self-quarantine. And so this just poses additional challenges for providers who are trying to provide quality care and have the staff that they need to really effectively care for those who live in their communities. Another issue is really just the incredible chronic stress faced by staff during this time. There's a lot of fear and guilt when I talk with our members around staff feeling fearful and guilty around potentially spreading the virus to residents, or perhaps taking the virus back home with them and spreading it to their loved ones. So providers are really working to try to support these staff members. Many have worked to offer increased pay for a period of time, bonuses, hazard pay, or ways to recruit folks. So offering hiring bonuses to help have staff that they need and to support and keep the staff that they have. So there were some folks who perhaps left the workforce for reasons, maybe they had a loved one that they needed to care for. They had a child who was not able to be in school any longer and they didn't have other childcare options, perhaps who left voluntarily to take advantage of unemployment benefits. This is not the norm, but there are examples of this as well, and these add to staffing challenges. And another consideration is that temporary staffing is currently costing sometimes as much as 3 times what it costed pre-COVID. So it's just an incredible financial burden for providers who are already facing some staffing shortages to really try to provide the highest quality care that they can. So then when we look at testing, assisted living was not broadly included in the universal testing order that focused on nursing homes. There were some assisted livings that were able to access test kits through the National Guard, but that was not widespread. So we, the cost for testing can be incredibly expensive. I had a CCRC member tell me last week that when they looked at what it would cost for them to pay for their staff to be tested just one time, it would be $35,000. And so as we are looking at what ongoing testing looks like in the state of Maryland, there has to be a way that we figure out how that's going to financially work, because passing that cost on to providers is not sustainable. So most of the testing in assisted living has been voluntary for residents and staff. We know folks have worked with their local health departments when there is a potential suspected case or a known case, and they've worked on how to respond to that. But really, we need to look at a way that the ongoing testing plan in Maryland addresses all settings that provide services to older adults, including assisted living and not just skilled nursing. Go to the next slide, please. So looking at the financial landscape of how COVID-19 has affected our field, assisted living facilities have really not received any specific federal or state funding to offset these increased costs that we've overviewed, including the staffing, PPE, testing if they've had to go out and pay for that on their own. All of the HHS provider relief funds that you may have heard about have been targeted towards Medicaid and Medicare providers. Some assisted livings and some of our CCRC members have applied for PPP loans, but we know that these programs, the funding has been limited and not everyone who has applied has received funds. And we also know that those funds have limited purposes that they can be used for. So it's really an ongoing challenge. Providers are reporting double and triple digit increases in monthly costs. Some providers have reported spending their entire annual budgeted amount for PPE in just 1 month. Other states have found some solutions. So Wisconsin and Pennsylvania have allocated monies to providers to cover increased costs. Maryland used increased in federal match funding to offset increased enrollment from unemployment. But really Maryland needs to provide funding to providers to really help offset some of these increased costs. And Dana, I think you had some things you wanted to share about how AL is financed in the state of Maryland.
Yes, and that would be the next slide. I do just want to add one other story because I can't emphasize enough the importance and challenges surrounding PPE. But I know that we had one provider tell me that when he couldn't find the PPE on the market, he actually went to a tailor. And I've talked to one provider in AL, but I've also heard this in nursing homes. And the tailor actually made him gowns that they can be laundered and reused, but those gowns were at a price of $45 a gown. So I do commend many of the providers for thinking outside the box and trying to figure out ways to procure the necessary PPE. Now, when we look at how assisted living is funded, at this point, funds, and also community-based services, Medicaid waiver, and there's a grant program that operates out of the Department of Aging. So if you want to go to the next slide. So private pay is basically the majority of how assisted living is funded. And according to the Genworth Financial Cost of Care 2019 survey, the average monthly rate for assisted living, and again, this is the average, is about $4,300 a month in Maryland, and that's a private 1-bedroom. Maryland's assisted living regulations only allow for 2 individuals to share a room. So again, this is the average. So it can range from a provider only taking SSI from the resident all the way up to $10,000. So again, we are a very diverse community. Long-term care insurance, I often get the question about that when we're talking about private pay. We have seen nationally and in Maryland double-digit increases in long-term care insurance. So we're really outpricing individuals from that in order to cover the costs. So again, the majority is private pay in assisted living. And again, these are seniors, so they're on fixed income. So increases to their costs will have that trickle-down effect. The next slide. Medicaid, as you all know, does have a small waiver. Last week, I reached out to the Maryland Department of Health just to find out how many individuals participated on that waiver and were receiving services in assisted living. So it's not just those who participate on that waiver because it's much bigger, but these are individuals who receive services in assisted living. And that number is 1,069. So again, if you go back to one of the first slides, which you don't have to do, there is a bed capacity of 23,000, but that you can see is a very small number of individuals who participate on that waiver. And one of the main reasons also is because providers and the reimbursement, the participation of providers, there are basically 4 levels. You can see I have listed, it's assisted living level 2 and assisted living level 3, and it depends on whether or not individuals also are attending medical adult daycare. But at the end of the day, if you go back to the slide that says that the average cost is $4,300, you can see that the rate of reimbursement provided. Now there's also a room and board and a cost of contribution by the resident if they're able to pay it. But you can see it is a pretty low amount that is provided. Now, the General Assembly recognized that, and in 2018, they required the Maryland Health Department to undergo a rate study to compare the cost of care versus the level of reimbursement. And this was for home and community-based services across the board. But for the medical, but for the assisted living, basically waiver, the study itself showed that these services were underfunded by about $40 a day. And we thought that was probably on the lower side. Because of that, the budget committees in 2019 requested that the health department put together a 5-year plan to try to bring rates in line with the cost of delivering services. The Maryland Department of Health basically reported later in that year that more information was necessary and that they were going to be issuing an RFP for contract work to do that. To date, the RFP has not been issued, but again, COVID hit in March. So I wanted to just make sure you were aware of some of those issues. And again, the limited impact that the assisted living communities have with Medicaid. Next slide, please. There's also a senior assisted living group home subsidy program that is operated out of the Department of Aging. There was actually a bill put in this session that would have increased the subsidy amount. Currently, it's $650. It's the monthly subsidy. It has not been increased since 2003. And according to the fiscal note on that bill, it serves about 552 seniors. So again, those are the 3 main funding options for assisted living. Again, it's very important for you to recognize it because again, when we're talking about the impact of COVID, the budgets of the assisted livings are limited and the relief that they have been able to get, especially from the federal government under the Provider Relief Fund, has been limited because those funds have only gone so far to Medicare and Medicaid. So next slide. And just to talk about the regulatory environment, because again, how we're regulated affects the impact for COVID. And as was mentioned by Secretary Kramer, assisted living is regulated by the states. It is not regulated by the federal government. So each state does it a little bit different and even calls it differently. In Maryland, each community has to be licensed and inspected by the Office of Healthcare Quality with the Maryland Department of Health. Maryland years ago, probably about 17 years ago, decided to go forward with a one-size-fits-all, which means that we have the same regulatory structure, whether or not you care for 1 individual or 200 individuals. That had been debated pretty fiercely. Like I said, 17 years ago, I represented this industry for 17 years. We've gone through 2 regulatory revisions, major regulatory revisions during that time. And that is always discussed, but so far we haven't made any changes. And of course, communities must adhere to state regulations as well as local regulations, and those include zoning. And then of course, OHCQ is required to inspect each licensed program on an annual basis. We do have provisions in the law for criminal penalties for programs that are operating without a license. And those are enforced. So next slide, please. So overall, again, this could be an entirely different presentation. So I just want to go through it quickly. Some of the major regulatory provisions, we do have assisted living manager and 80-hour manager training course for the managers. There is a delegating nurse requirement, and those individuals who are registered nurses must go through a training program with the Board of Nursing. There are training, initial and annual training for staff, including a competency evaluation for any non-certified individuals that must be done before direct care can be provided with the registered nurse. And there are 3 levels of care that is part of your overall licensure. But I will tell you, even though there's level 1, 2, and 3, the supermajority are licensed for level 3. Next slide, please. And basically the next few slides, I think there's just 3 of them, kind of go through, the regulations are 178 pages. So they go pretty in depth through all of these different issues. You can see we have resident agreements, which go into both the non-financial and financial. Every resident has to have service plans, resident records. The regulations talk about the type of services provided, Alzheimer's special care units, relocations, discharges. Next slide, please. And I'm not going to read it because everybody can read these to save time. But again, I wanted to give you an overview of really what the regulations are addressing. And just next slide. Okay, and that's our contact. Actually, can you go 1 slide back? Thank you. 1 more. No, not 1 more. Go 1 forward. 2 forward now. It's very hard when you're not actually controlling it. I did have a question that I was asked to discuss regarding resident funds, because again, there has been a concern that without visitation being allowed to go, visitors being allowed into the assisted living communities, that operators or communities are managing resident funds. So I did want to just talk very briefly about that. And that is discussed pretty in depth in the regulations right now. An assisted living program can only manage resident funds with the express written request from the resident or the resident agent. And then if they are, the assisted living program has to develop adequate safeguards to secure the personal funds. If they're over $300, they have to be deposited in an interest-bearing account. And an assisted living program that manages residents' funds, regardless of the amount managed, either has to have a bond with the state, a letter of credit, or net assets equal to the average monthly balance of all the funds held. Those are subject to inspection by the department and must be available for audit as well. And of course, if there is any issues regarding that, they can always be sent to the Medicaid fraud unit if it's a Medicaid provider, or sent to the appropriate enforcement agency. So that was asked of me, so I did want to clarify that issue. So that pretty much says the end. I think that's the end of our presentation. And we thank you for the opportunity.
We thank you for a lot of information, and we know that we still are relative dummies and we need to know a lot more. I see a couple of hands raised. Senator Augustine has a question or comment, followed by Senator Feldman.
Thank you, Madam Chair. And thank you, everybody, for the presentations. My question actually goes back to Ms. Ellis, and although it is a continuation through this, and what I wanted to know going with the Ombudsman program is we're under very stressful times right now, but how is the information about the Ombudsman program getting to the residents of these facilities and to their families? And is there any kind of an obligation or a requirement that they get that information? Because I get a lot of times where people are asking for help with the interactions with the institutions. So if you could just share that with me, I'd be great. I would appreciate it.
Okay. Do we have a response to that good question? Or is it something we could follow up on and get back to Senator Augustine regarding? Anybody? You know, we're new at these virtual hearings. It takes us sometimes to move from one modality to another also. Okay, well, I'm going to suggest, Senator, that maybe getting back to Dana might be a good way. I think she's been at this longer than anybody else in the room right now. And so why don't we go to Senator Feldman's question?
Madam Chair, I just unmuted. It was blocking me from
I see, okay.
unmuting. Stevan, can you unmute so that I believe she wants to answer. She cannot be unmuted. She's got your response, but she needs to be unmuted.
Thank you.
There you go.
Can you hear me now?
Yes.
Yes.
That was my sign language. You couldn't hear me. So the facility is required to let the residents know about the Ombudsman program. And what we've been doing, we had regular visits before, and so the facilities were aware of us. We brought brochures before, and we've been doing that since. We've been doing mailings to them, emails to the providers, setting up calls. I required my staff the first couple weeks of the pandemic to call all the assisted livings and the nursing homes to get them on the phone to remind them that we're there for them and to let the residents know that we're there. And that's kind of how we've been sharing information.
If I could add to that, right now, the Department of Aging is running public service announcements that we're paying for to let the public know that the Ombudsman program exists and how to reach the Ombudsman program.
Okay, very good. Okay, we'll go next to Senator Feldman.
Thank you, Madam Chair. So actually, if we could unmute Dana Kaufman. I had two things she brought up I wanted to kind of get a little feedback. So number one, maybe you mentioned this, but I just, in terms of, on the one hand, we say that there is basically the same regulatory structure at the state level, whether you're caring for one person or 200 folks. And then when we transition to the reporting of deaths and cases, you indicate that unless it's everything under 10, which is like 90% of the entities we're talking about, there is no requirement to report cases or deaths. So what is maybe again you mentioned, but what would the policy rationale be for this cutoff of 10 beds? Because it seems like we're not capturing this massive potential number in that space. And then the second question, unrelated, and Dana, you can kind of, our committee is the one that passed the emergency bill that included price gouging. So it does trouble me a little bit then when we talk about price gouging on the PPE. I mean, has there, in the experience of the folks that you're involved with, I mean, has there been any I don't know, reporting of that experience to anybody, because we actually amended the bill to specifically insert provisions dealing with price gouging. Now, you made the point about some of the pipelines are international and national, but the fact is they're doing business with Maryland, at least with US companies, you know, that would subject them to the jurisdiction of the Attorney General, state. Like, it just bothers me because, you know, again, we made a concerted effort to deal with what we knew would likely be a problem, the issue of price gouging, and it's happening. And yet my gut tells me that, you know, there's nothing happening on that front. So those are two specific separate issues, Madam Chair, I wanted to maybe put to Dana.
Sure, thank you. And just to clarify, so Maryland's regulatory structure for assisted living is a one size fits all. So regulations basically provide minimum standards. So those minimum standards apply whether or not, like I said, you're caring for 1 or 200 individuals. Now, as it goes to reporting, all providers must report to their local health department. So if you're caring for 4 individuals and you have a COVID positive or a COVID death, that has to be reported to your local health department. But the dashboard that is on the Coronavirus Maryland website only lists those facilities or communities where there are more than 10 beds. That is a policy decision that was made by the health department. I can't give you a reason why that was done, but I do want to make sure that you understand that they, regardless of the number of individuals, it's my understanding that everyone,
Okay.
all have
Okay.
to report.
Okay, so we're clear. The reporting requirements there, it's just the Department of Health has made a decision to make a cutoff at 10 themselves, right? I mean, like, we didn't have any input on that, and nobody, I mean, that, I don't quite understand why that would be. It's given us a, you know, a somewhat skewed, understated number. Everybody looks to the dashboard as being the number that's representing, you know, the important numbers and trend lines. Okay, fair enough. That's helpful. What about on the price gouging?
Oh, yes. For the price gouging, I think that that's a very interesting question, and it's one that I've actually wondered about myself, because I mean, I even heard it again with the Hospital Association on Tuesday talk about the issues, and Delegate Kelly is nodding her head because she was there. The issues that we've had of finding affordable and necessary PPE. To the best of my knowledge, I don't know if the Attorney General has looked into this issue more closely. I know that in gathering and, you know, the PPE, you know, as associations, frankly, we were just in that spot of trying to find reputable companies. Believe me, that was a hardship in itself. But I don't believe we have done any specific reporting. But I mean, I will tell you that, you know, gowns used to be, you know, $1 a gown. They went up to like $7.50 a gown. So we really did see spikes. Now, again, I am not an expert on the price gouging law, so you would be much more than I am if that's a situation of, you know, supply and demand or a price gouging. So I think that those are all legitimate questions that in hindsight we need to take a look at, especially right now as we prepare, hopefully just prepare and not have to deal with second and third waves. I'm going to be optimistic.
Okay, thank you, Madam Chair. Thank you.
Okay, I'm going to report to you guys. I don't know what happened technologically, but I've lost the ability to see you guys. So I know that we had the Speaker Pro Tem Sample Hughes on, followed by Senator Bottle. So if the two of you would make your comments or ask your questions next.
Okay, here we go. Thank you, Madam Chair. I'm a little technology difficult sometimes myself, but thank you again for having this hearing on today. I have 2 questions, one for Secretary Kramer, and then Dana, if you could probably highlight this. I know with the COVID-19, we have been able to unmask And it's becoming more apparent to the general public of the disparities within numerous areas. And today we're certainly talking about assisted living facilities. I've always had the concerns about your staffing, the staffing requirements of living facilities. And I'm really kind of talking about your smaller ones where we're looking at that they're having to serve numerous roles. And given this time, I'm just curious, how is that being done properly to ensure quality is undertaken? Because they're having to be the role of the providing the food, providing the activities, providing the mental health capacity or assistance that is needed. So that's a concern for me. And I think we still need to look at that closer overall as a best practice to ensure that staffing remains a priority in these assisted living facilities. My second question, which is for Secretary Kramer, you had mentioned that Ms. Ellis, her role has been or is to go in to address complaints in long-term facilities. Would you advocate for her to be an essential employee right now to go in and check on to see if there are complaints and things are taken care of properly in our nursing home facilities?
May I answer the question to me, that latter question first?
Sure.
The reason that our ombudsmen are not going in, and it's not just one ombudsman, Stevan Ellis is the state ombudsman, but she has a very large number of ombudsmen throughout the state who work with her, who are highly trained, but that go to other facilities. So we're not talking about one person because there are far more, too many facilities, far more than she could handle on her own. So we're talking about having a tremendous number of people out in the community who would be traipsing into nursing homes and assisted living facilities. It is not our decision at the Department of Aging to make those health decisions about whether it's appropriate yet for people to go in. But I can tell you, I certainly can see that it could cause a spark in cases if we have one person who's an ombudsman somewhere in the state going into a facility asymptomatic, and they could cause a huge problem, a wave of cases. So the Department of Health has erred on the side of caution and kept these many ombudsmen out of facilities. So it is, and I can let Stevan speak to the way that they are handling getting information and speaking with residents. They have not walked away and said, we can't participate in our advocacy for them. Not at all. They're working harder than ever. They're using other means that are less likely to cause cases and possibly deaths in the communities. So at this point, any decision that would have to be made would be made by the Department of Health, not Aging. We don't have that capability, but I certainly see the rationale. We wouldn't want one of our parents to be exposed to COVID because we had one of these very many people throughout the state traipsing in and out and going from one facility to another where they could possibly be carrying it.
Mm-hmm. Thank you for your response. It is a little disappointing that we don't have the Department of Health Care Quality here on this call, but certainly given the fact that a lot of these policies and decisions are being made within that department, it just makes sense to have them on board with this conversation. But I'm certainly willing to listen to Ms. Ellis.
I just butt in to say that we tried hard. The health department told us in so many words, they're really backed up right now. We'd have to go on without them. But obviously we need that follow-up.
Sure, thank you.
I just wanted to let you all know across the country, none of the ombudsmen are going into facilities except for very specific situations. There is an exception for compassionate care complaints and also very extreme situations like relocations and that sort of thing. we're planning for when we do go back in. So I just wanted to let you all know nationally, we have a national planning group, and in the state of Maryland, we're talking about when we would go back in, making sure that we're prepared, that our staff have good infection control practices and those type of things. So we're working whenever we're allowed to go back in, all of us, for normal visits, whatever that looks like at that time. We're preparing for that right now. But we are, in the meantime, trying to do as much as we can remotely. So we're really doing a lot of outreach to facilities to make sure people know about us. And we do have a lot of people contacting us right now, and we're following up with them by phone, by email, virtually, and all of that. So please, if anyone does have a concern and would like to talk with us about assisted living, nursing home, even just to get information, because we do a lot of education and resource information these days to help people understand what's happening, and frankly, to provide a lot of support. Please send them our way.
Thank you. Let me ask, since the question came up, what is the level of your staffing right now?
So we have, I'm not sure if you know how we're structured, so I'll answer that way. We have 19 local offices across the state, so one in each county, and then on the Eastern Shore, there's multiple counties. We have 3 offices that cover, one office is Queen Anne's, and then the other 2 cover Upper and Lower Shore, respectively. We have over 40 paid ombudsmen, and we have over 100 volunteers. And they all have the same authority to go and visit with residents and well, normally visit with residents, but do the ombudsman work the way that we always do it.
When you consider the configuration of assisted living in Maryland by counties, some smaller counties have very few and limited numbers, and some other counties are really running over. Do you think there are any needs for reapportionment of the staff to make sure you have the people placed where they need to be, or is that not a problem?
In counties that have larger numbers of facilities, like Baltimore City, that has over 400 assisted living facilities, the Ombudsman program looks at the facilities with the greatest needs, the facilities that have issues going on, facilities that haven't received a visit recently. And again, I'm using visit and just put a substitute phone call for right now. And that's how we do it. So we base our staffing and our approach based on what the needs are at the time. And especially now, and if a facility has a lot of positive COVID cases, that's also a big prioritization consideration for us right now.
Okay, thank you.
You're welcome. Thank you.
Could we hear Senator Vital's question? Oh, yeah, okay, Dana, go.
All right, I just didn't want to not have a chance to answer Delegate Sample-Hughes. So I'm going to answer it in 2 parts, kind of the more narrow staffing issue and then the bigger picture. So more narrow, the assisted living regulations do require that an assisted living community have sufficient staff to meet the scheduled and unscheduled needs of their residents. There are also provisions regarding awake overnight staff and on-site nursing requirements, because again, the assisted living model does not necessarily require a delegating nurse, which has to be a registered nurse, to be on site at all times, but they have to be on call all time. They have to be available on call at all times. But if there is a reason through either the delegating nurse or a physician's order for certain nursing services to be provided, then they must be on site. The bigger picture, though, as has been stated, is not just in assisted living, but we are going to have a shortage of direct care workers. We know it's coming. We think COVID has actually pushed that forward a little bit more because staffing during this time, as Allison indicated, has been one of the biggest challenges, and making sure that we can afford the staff. It has been basically a budget buster for communities, but it's also an opportunity because unfortunately with the state's rate of unemployment, there are going to be jobs that just don't come back. So I know that we've been working with the Maryland Higher Education Commission and with the Department of Labor to try to figure out how we can pivot individuals into training programs for senior care provider positions. So we've had some very good conversations, and we're going to continue to have them because we really do, as a state, need to make sure that we have the appropriately trained staff to cover our increasing senior population. So we think that there is some exciting opportunities and different opportunities for training. We're really looking more on some online training certifications for these individuals. So hopefully that helps with your question.
Very good. Let's go to Senator Bottle for her question or comment.
Thank you, Madam Chair. Thank you for the meeting today. I have a question, but before I go to my question, I'd like to share something from Kathleen Murphy from Maryland Bankers that's listening in on our call. And she said she heard someone say that PPP, Paycheck Protection Program, was no longer available. There's still $100 billion available. And if your local bank is not taking your application, you can contact Maryland Bankers and they'll help you find a bank that will take your application, but it must be submitted before June 30th. So for those listening, there is still money available through the PPP program. So if there's any questions about that, I would say reach out to Kathleen. 60% of the loan needs to go to payroll and 40% can go to non-payroll. If folks need to apply, they need to do it quickly. So thank you, Kathleen. My question has to do, again, with the dashboard and the numbers, because I've been following it very closely because I have an uncle in rehab now that is actually contracted COVID while he's been there. And so I've been living this nightmare, and they've been a very good assisted living. They've given us updates every day. We have a Zoom call, which I couldn't listen to today because it's always at 1 o'clock. And every day they give us update on how many more people have been affected, how many more staff have been affected, how many have passed, who's in the nursing home, who's out of the nursing home. So I look at these numbers from the dashboard. We had 6 days without any update at all. And now the update from today is down 294 from the last update, which was June 6th. So who can we go to get accurate dashboard numbers, and who's responsible for updating the numbers? Well, I'm just very concerned that we're not getting any realistic numbers of all what's happening in our nursing homes and assisted living.
All right. Now, I told you guys a few minutes ago, I'm flying blind. So at this point, I can hear you guys, but I don't see you. So if one of our experts has a response for Senator Bottle, just step up and state your name.
Madam Chair, thank you. This is Rona Kramer, and I would like to address that in general terms. We don't keep the dashboard. I can't give you the day-to-day differences and why that might be, but I can tell you when the article came out in the Baltimore Sun this morning with a headline that says Maryland significantly underreports total coronavirus cases and deaths at nursing homes. Of course, I was concerned. I looked at the charts that they refer to, the dashboard, and it clearly states on that same page, right under the dashboard, it clearly states that facilities are removed from the list when health officials determine 14 days have passed with no new cases and no tests pending. And that doesn't mean that the historical information is not available. It is. It's just not on this particular dashboard, because the purpose of this particular dashboard is to give a snapshot in time, current. So people go on, they know that this is the current data, and the number of cases that are current, we use that 14-day period, and it clearly states it. I went back to the Department of Health and I said, has this language been here since you've been showing the dashboard? They said, it is exactly as it was written for the past 2 weeks that I just read you. And prior to that, it also said that they're removed. The language was slightly different and they decided they could clarify it more. Prior to this, it says, until 2 weeks ago, said facilities are removed from the list when health officials determine there are no longer active cases at the facility. It clearly states that this is one piece of information. It is current for people who are looking for how many cases there are currently. in the Department of Health's information that is also posted on their coronavirus website, it states all of the historical data. So this headline, yeah, I can't imagine how this reporter used this headline if the reporter read what is right there with the dashboard, the language that says this represents information that has not been removed because it's current. And the information, if the reporters had checked, is available. So anyone looking for the total history is there. So it is very inappropriate. And anyone reading that without going right to the source wouldn't know that it's written there on the source that it is current information, and it states that it is. There was a quote from a legislator in this article stating that if the information is wrong or the data is fudged, the data is there and it's marked. And there is no reason to believe that the governor doesn't have all of the data and that the governor doesn't use all of the data when he reports it. This was just taken entirely inappropriately. So I'm very disconcerted to have seen that. And I've got the language in front of me as it's been written right there with the data.
So, Madam Secretary, if I can respond, I'm looking at, I get my numbers every day from WBAL and the nursing home congregate facility data, and it doesn't have any comment like you just made, but it doesn't explain to me what you just said, why we went 6 days without an update and why the deaths have gone down from 1365 to 1342.
Yeah, I don't upload that data, so I'm not familiar. I can't give you something specific as to what's actually happened over the last 6 days. I can't tell you that. I can't, but I wanted to respond to this accusation, which couldn't be farther from the truth.
I think everybody's trying to tell the truth on this issue. It's that what people think they are looking for is at this point in time, if you give us successive days or successive weeks, what the numbers are, how they've all accumulated. And so I think you've cleared up something that's probably accurate in terms of the way the data have been reported, and that nobody told a lie about what they reported. But most members of the public, seeing how many have died and how many are ill in nursing homes, in spite of the fact that they don't single out the assisted living and they're in there somewhere modeled, and we don't know how many are there, would suggest that we could do a better job in the future of defining each time the numbers are there for the public, what they represent. And most people are expecting that if you tell us in successive days how many died, that they aren't less or the same amount than at some earlier point in time. So I think what we're saying probably means that a lot of good people of goodwill aren't quite sure. And I believe Tammy is trying to tell me something, and probably
Yes.
are perfectly out of time.
Chair Kelly, no, the members with questions are Senator Klausmeyer, Senator Benson, and Senator Eckert. So we'll just.
Then why don't we take your three in that order? We'll start with Klausmeyer.
Yes, yes, please.
There. Secretary Kramer, I just have two quick questions, and then actually it's three, but how do you choose your restaurants that you're getting your food from? Because
Thank you. Our area agencies on aging are going out and putting out requests for proposals to their local restaurants
Okay,
and are looking for participants. So if you've got restaurants in your district that you would like to recommend to the program, you can let us know. If you don't want to go directly to your AAA, we're happy to take that information and make sure that your restaurant is contacted.
okay, I will
Could
do
I butt
that.
in before you ask the rest of your question? The food that is being purchased this way is going to individual seniors who live at home and need groceries. Is that correct? Or is it going to assisted living or to nursing homes?
This is for our individual program.
Okay,
So it will be home delivered. The majority are home delivered meals. There are some that are grab and go, where they might drive up to a location and pick up their bag of 5 meals for the week.
thank you. Back to Senator Klausmeyer.
Yes, and who do you accept the equipment from that you clean up and can pass on to others?
For the durable medical equipment
Yes,
program,
yeah,
we take that from anyone in the public. It has not formally opened. Our schedule was to open it about August 1st, if
Okay.
COVID allows us to do that.
all
But
right,
we'll be collecting equipment prior to that. So
okay.
we will put word
Because
out.
I belong to a Lions Club and people are always giving us things, so. And the
So do I.
the
I'm in a
211 call center and the service corps, is that all on your website so I can look all that up and put it on my Facebook?
It is absolutely, and if all of you would like to have information on these programs, I'd be happy to send it out to you all with links so that
But yeah,
you can send that out. So
that would be great.
make it easy for you. These are all we're the first in the nation to have these programs in Maryland.
Thank you so much, Madam
Okay,
Secretary.
thank you.
All right, we're going to Senator Benson.
Yes. Yes, can you hear me?
Yes.
All right, thank you very much. Thank you, Madam Chair. Thank you all for this presentation. You know, we're trying to eliminate the spread of this disease. And so what I just heard in the presentations is that the testing of all nursing home and assisted living resident staff and contract caregivers are optional. I'm just wondering why we have not mandated that all persons who are resident staff and contract caregivers are required to be tested. If we're trying to eliminate this disease, I don't understand why it's optional. What can we do to ensure that each person who is working in these nursing homes and these assisted living facilities have testing? And the second thing I wanted to find out was, what can we do about this whole problem of the PPE kits, of the testing kits? The PPE, what can we do to ensure that these agencies have enough equipment and materials to deal with this problem that prevails in the nursing home and assisted living facilities? What I'm hearing from people is that who work in these facilities is that they have to go out and purchase their own masks and gowns. I'm just wondering, how can we deal with these two problems?
Could I respond? I'm not responding for the Department of Health, so I can tell you what I know from having been on many calls. And first, please understand the backdrop of this is that the entire world was hit with the pandemic at the same time, which means that where we used to go out when the flu would hit in one region of the country, we'd get assistance from another region of the country. And then when things got bad for them, we would help them out. We'd work back and forth. Everyone was hit in the world at the same time. The federal government was not providing the PPE nor the test kits for us. and every state was out there trying to procure it at the same time. Very, very intense. And we're procuring it from countries that are also facing the same pandemic. And so they were either not manufacturing it because they were in a pandemic shutdown, or they were keeping it for themselves. So we were in a situation that we have never experienced before. And it was horrible having to deal under those circumstances. What we did in Maryland was immediately start procuring. And there were times when the state of Maryland was competing with other states to buy PPE or to buy test kits or test kit material. And that's a terrible position to be in, but we had no choice. So we had a team of people in the state who were working, I can tell you, round the clock, because I was on the phone with them many, many times. I can tell you the governor's staff, the executive branch, has worked round the clock 7 days a week. I put in myself 18 hours a day, 7 days a week through most of this pandemic. And there are others in the Department of Health who were putting in more hours. So procure, we tried procuring. The other leg of this was that we had to flatten the curve, because while we knew that we couldn't procure enough ventilators to serve everyone, if we peaked the way other areas like New York did, we had to flatten the curve and worked very, very hard to flatten that curve, as well as to set up thousands of additional hospital beds, ICU beds, so that if we did have that huge surge, we could deal with it and no one would go untreated, as we saw happen in Italy. All of this happening at exactly the same time, and the Department of Health guiding this all at the same time.
You're
So-
giving us a good sense of what it must be like from the inside out, trying to help to manage it. We want to try to get one last question in, and I think Senator Eckhart was on the list, if we could hear her question or comment.
Thank you very much. I had two questions, and probably I presented them in the reverse order. First, thank you, Chair Kelly and others, for holding this. I think it's very important. And the first question is, do we have an accurate case, an accurate number of the cases of COVID broken out, not only by nursing home, but by assisted living facility? I know, isn't that information aggregated or not?
I can't answer that, but maybe Stevan could or Dana could.
So this is Stevan. The nursing home data is posted, and also, by the way, if you go to the website, the COVID website, there's a search box, and you can put in a question and actually find the historical data too. So I just wanted to point that out since that was brought up earlier. The small assisted living data is not. It's not. I don't think that information is public. The 10 or larger is. So you should be able to see the historical data for the nursing homes and the larger assisted livings. And Dana, if you want to add anything to that.
No, I think that we've kind of talked about that. And I would encourage that really that information is controlled by the Maryland Department of Health. So they would be the best resource to really be answering these specific questions. And if I can just add one point about the PPE, not to backtrack, but I do think it's very important going forward, is that right now, as Secretary Kramer had said, in the beginning of this, everybody was scrambling to find PPE because the normal supply chains just didn't have it either. But I will say we are in a much better spot now than we were back in March. And really what we're trying to do is continue that purchase of PPE. And I know for Lifespan, the association, and I'm sure Allison would say the same, We are constantly sending out vendor information to our members, but we have even taken the step further, and we have become our own little distributor by purchasing in bulk for cost. And then it gets shipped to the Lifespan offices. And every day we have facilities picking up, and they really aren't picking up for what they need today. They're picking up for what they anticipate they are going to need moving forward. And we've also talked about that this is something that is going to continue in the long term until this virus is eradicated or until there's a vaccine. So I just wanted to leave you with that point that currently we are in a much better place than we were months ago. But again, cost is always a factor as moving forward.
And Senator Benson, the state is working very hard to become independent in producing and providing some of that too, so that as we move forward, we have accessibility.
Okay.
Thank you. Can I finish?
What is it?
That was part of my question. That was part of my question, but my comment was we're addressing the assisted living facilities and for our seniors, correct? We're not addressing TD or behavioral health because I know there have been issues with those as well, just with regard to PPE. So thank you very much.
Okay. I want to thank everybody, and there are questions that I'm sure are unanswered. You'll think of some while you're dreaming tonight, and we can come back on an individual basis, or some of us might want to sit collectively once we can have actual meetings to see what else we need to know. The last regulatory work done in this area was based on, I think it was Senate Bill 218 in 2018. And maybe more needs to be done based on what we're learning, what we're seeing, the way this pandemic is playing out and the impact that it's having on these services on which we need to rely. I want to thank everybody for participating, and especially those who gave us the 4 major presentations today. And we might be back in touch very soon. Thanks so very much.
Thank you.